Great. Dr. Rohini Sharma, thank you.
Thank you. And thank you very much for the invitation to speak today. As the only medical oncologist here, I feel like I've been invited to the lion's den. So, hang on, I've missed a... Oh, I think there's a slide missing. Okay, it doesn't seem to want to go to slide 2. My slide number 2 was going to state that actually surveillance adherence is very poor. So what we know is that whilst we're inviting a lot of patients to surveillance, less than 25% of patients actually engage in regular 6-monthly surveillance. Now, there are a number of reasons for this. Firstly, there are patient-related barriers, which I'll go into more of. There are physician-related barriers, and there are system or healthcare-related barriers. All the work in this barrier work, all the barrier work has been done in the US, and what we don't have is a UK understanding of why our patients do or don't come to surveillance. We conducted a series of co-design workshops, and the idea of these workshops were to ask our users who have lived experience of liver surveillance why they do or don't come for regular appointments. And this was all done by my clinical fellow, Maria Qureshi. We also wanted to work with our users to try and develop appointment letters and invitations for people to actually come to their appointments. These sessions were facilitated by Claremont Communications. We had 23 participants, including representatives from relevant charities. And these included a diverse mix of people, so varying etiologies, various literacy levels, gender, race, and we used a COM-B model to analyse the sessions. So all these sessions were recorded, and following that, we then analysed the sessions. I think what the key points that came out from patient-level barriers were some of the things that we've already alluded to this morning. So one of the key things was that patients said they just did not understand the letter that we sent us. There was a lot of medical jargon used, and some people had low literacy levels. An example for this is a lot of radiology letters went out with your US is at this time. What does US mean? If you're a patient, you have absolutely no idea. There was also a lack of awareness about the importance of these appointments, and it was felt by users that their doctors were too apprehensive about using the word cancer. As an oncologist, I use it all the time, but I do see that a lot of patients will come to my clinic, never have been told that they had cancer. And I think this then leads to deprioritization by the user of their appointments. If they don't know why they're going, they might not actually want to come. Then there were lots of issues about denial about liver disease and consequences, and this overarching fear that a lot of users expressed about what would happen if I am diagnosed with something abnormal on my ultrasound. One thing that did come out, particularly in the people who were experiencing homelessness, was this issue of pessimism and fatalism. And something that we've already touched on was this idea about stigma that patients felt that they had from their healthcare professionals. And certainly we've done some surveys now of our healthcare professionals, and concerningly, there was also stigma that healthcare professionals did express towards users. So we asked our user group, how would you like to be appointed? How would you like to receive your appointment letters? The first thing they said that they wanted their letters coming in white envelopes. Brown envelopes were felt to be from the HMRC, and they went straight into the bin. They wanted us to use plain, simple English, and they very much wanted the word cancer. We found this surprising, but our users all said they wanted to know that this surveillance was to find cancer. They also insisted on a graphical postcard, which Pamela very kindly has highlighted, to explain the surveillance process. They felt that this postcard would be very useful to put on the fridge, that they could explain to their family and their support group, and also to remind themselves about the process that they were going through. They wanted digital reminders sent in the run-up to their appointment. What was really interesting is that they did not say that they wanted a patient navigator or a CNS. Now, as being part of the rollout for the surveillance program, I find this very interesting because a lot of centres have been saying that they want a Band 7 nurse, they need a navigator, but the users themselves did not express this. I wanted to show you the appointment letter that we designed, and the idea is this appointment letter goes out at every single appointment stage. So every 6 months they receive this appointment letter. The appointment letter is very simple to understand, plain English. The users wanted to have a quote by a general practitioner because they thought that there was a lot of high level of trust in their GPs, and they felt that that would make them feel more at comfort. They wanted statements like liver disease can be caused by a number of causes to try and reduce the idea of stigma. They wanted the next step clearly highlighted again so that if there was something abnormal, that there was a process moving forward. And they wanted a link to a healthcare charity such as the British Liver Trust because they felt that that also enabled more trust. And this is the postcard that Pamela has shown before. So what was really interesting is some of the users actually thought an ultrasound was an invasive procedure. And so we were very particular to show a close-up, really indicating that this is a non-invasive procedure and that it was quick, it was painless. The users wanted background in green because it highlighted wellness and healthiness. And so this is the postcard that the users really wanted mailed out to them with their appointment letters. So what about the role of a navigator, given that everyone's been talking about navigators and we've heard the idea of navigators being supported by the program? So there is very minimal evidence in terms of randomised controlled trials looking at navigation through screening programs. The evidence particularly comes from helping patients from marginalised backgrounds in terms of engaging them into surveillance program. That has been shown in these situations to improve uptake, particularly in bowel and breast screening. There is only a single study in HCC done in the States where patients were randomised, 1,800 patients, to either usual care, mailed invite, or a mailed invite plus 2 phone calls. So patients received a phone call when they were invited to come to surveillance and 2 weeks prior to their appointment. What was really interesting is that you can see on this graph here that usual care, the rate of uptake was around 10%, and there was a 10% increase in the surveillance uptakes at 6 monthly surveillance every 2 years just by receiving an invitation. The use of a navigator only added an extra 5% of attendance. So that just shows that the biggest difference was actually in the mailed providing information out to our patients. Now, what's the problem with this study? Why am I thinking that we should do this again? Well, what was really interesting is in this particular study, even in the navigator role, only 23% of patients attended every 6 months over an 18-month window. So I think we can say the US model isn't reflective of what we can achieve in the NHS. And the other key thing is there was no cost effectiveness in this particular study. So what we're proposing is a randomised controlled trial called VIGILANT in terms of how we best invite our users to appointments. The primary objective is to really evaluate the impact of these bespoke invitations that we've created with users with or without navigation on attendance rates. The secondary objective is to compare the number of HCCs diagnosed and the stage of diagnosis at each group and to evaluate the cost effectiveness of each intervention. So this is our schematic here. So we've got 328 patients who are randomised either to get the invitation plus the postcard, and 328 that will be randomised to the navigation arm. They will receive the invitation and the postcard and a navigation phone call. Patients will be followed up for 2 years. The mailed invitation arm, as I said, it's very straightforward. The imaging will be requested by the relevant clinical team. Patients will then receive the bespoke invitation and the postcard. They'll get a reminder text message 2 weeks prior to their appointment. Results will be sent to the GP, the hepatologist, and patients, as we've already heard, they will receive their results on the Patient Knows Best app. Any non-attendance will be followed by a further appointment or text message, and patients that fail 2 appointments will get a phone call in order to try and understand what their barriers were to surveillance attendance. In terms of the navigator arm, everything exactly the same, except that patients will also receive a scripted phone call 1 week prior to their appointment to really talk to them about the actual process, remind them of their appointment, reschedule if it need be. So the whole idea of this trial is to define a cost-effective way of inviting patients to surveillance appointments. And I think the key thing is this has been underpinned by user engagement. We've had users design the intervention as well as the question. And I'd like to thank the charities that were involved in developing the protocol as well as our funders. Thank you.